Everyone has food? Everyone who wants food has food? And we have wine too. So we want everyone to relax. So I want to say thank you to everyone for coming and participating in this, which is really a pilot. It's just kind of, we're giving this a try and see how it goes. And we welcome Karen, who is in Penticton, on our screen. Okay. So this is called, we decided to call it Pediatrician and Local Community Professional Exchange. So the idea is to bring everyone together in a room. People that want to talk to each other about children, development, mental health issues, things that we're all involved with. And I want to just tell you a little bit about the why. So it starts with us pediatricians. So pediatricians, put your hands up. So it's about half the group are pediatricians here. And we know what to do when a child has some bad disease. We know what to do when a child has some not very bad disease. Physical stuff, it's very clear. That's what we learn in medical school and in residency. We learn some stuff about development and behavior and all that jazz in residency too, but we don't learn about all of the other folks in this room, the people in the community who are dealing also with kids. And we don't really learn how we're actually sometimes trying to do the same thing. We don't know about the resources that are there. And the resources don't know the things that we know. So it's not part of our curriculum, and I think it's not part of your curriculum either. And very often pediatricians say, what can I do to help my child? I know that there are things out there. I just don't know what they are and how to access them. And I only have limited time and effort to put into trying to find that. And so it's kind of with that idea. From time to time, I have spoken with someone in the community and mental health team or a social worker, someone from the school, and we chat about what they are doing, and we say, gosh, I didn't know that you did that, and I didn't know you were available to help me in this way or help the patient in this way. And we say, well, we should get together. But then it doesn't happen. It didn't happen until I mentioned it to Stephanie from BC Pediatric Society, and then it happened. So I think we just have to say thank you to Stephanie for making this happen, because it really wouldn't have otherwise happened. So Stephanie from BC Pediatric Society and Pat Zielinski, who was assisting, who isn't here tonight. And we also have Shire to thank for providing us with this lovely food so that people are willing to come out at 7 o'clock, 6:30 on a horribly rainy night. Okay, so I think what we're going to do, let me see. How do I advance? Let's try that. Okay. So I think what we're going to do is, when you come to meetings like this, everyone has to introduce themselves, right? So it's a large group, but I would like everyone just to say who they are and basically what you do, very briefly. We're going to be asking the folks who are in the community to say a little bit more about what they do, but that will be later. So I'm just going to tell you what we thought would be the structure for the evening. And really, the structure was kind of, we thought, well, we want everyone to be in the same room. We want them to talk to each other. And how are we going to manage that and make it useful? And we could do it sort of topic-based, but I thought what we pediatricians do in our offices is we see individual patients. We may make diagnoses, we may not be able to make diagnoses, but they're all individual people, just the same as the people in the community are dealing with individuals. And you can say that a particular treatment might be indicated, but in fact, sometimes the reality is not quite the same as what you want it to be. So I thought that it would be useful to start with some cases. And we had asked, actually, the BC Pediatric Society folks that we sent out emails to send us cases, but I think we kind of had part of one case from one person. So, because it's hard to come up with appropriate cases to present here. Anyway, I brought 4 cases of my own, for better or for worse, so we can look at that and then just sec. So we're going to introduce ourselves, then we're going to go through these 4 cases, which I think will take, I'm hoping, till about 8 o'clock. And you saw, sorry, on this slide, we have learning objectives tonight. We have learning objectives because we are actually CME accredited, and so we are actually, the doctors here are going to get how many hours? We get 2 hours for participating tonight. So these are our objectives, and it actually focused our thinking. We sent them around, and we're going to discuss each case about kind of around the first 2 of the objectives. What are the needs of this child? And then what is actually available in the community to help this child? And then, as I say, an open discussion about these things. So I have 4 cases that we can talk about. And then at that point, I thought it would be nice to invite our panel, which is our non-pediatricians in the room, to tell us about what they do, because I think that once we've heard about the cases, it can help focus your own thinking about your own cases. And I'm sure that folks here who are invited to present to us it will stimulate their own thoughts about what's appropriate for our patient population. And then we can do some summing up. So that's kind of what I was thinking that we would do. And obviously, this is meant to be a discussion. It's not meant to be a lecture. And it's really meant to be what people want it to be. And so with that in mind, I really encourage people to speak up. So let's go back to introducing people. Okay, so I'll tell you who I am. I'm Elisa Lipson. I'm a pediatrician, and I have done general pediatrics in Vancouver for 25 years, and I see lots of children with behavior, development, and mental health issues. Okay, so Kelly, do you want to take it away?
So I'm Kelly Whitaker, and I'm a pediatrician. I work at the local acute care, and I'm also the pediatrician at the hospital and all the clinic here at the hospital.
I'm Sarah Friedman. I'm also a community.
We should probably have some light.
I can pass. Yeah, we can use the wireless mic to pass around.
Actually, they could just use the mic there, probably, Jeff, so that we
Yeah.
can actually show them how to use it.
Yeah, if you push it, then
Okay. I'm also a community pediatrician. My name is Sarah Friedman. Mostly locumed for my first year out and currently on mat leave.
That's okay. I have a very loud voice.
Wonderful.
Oh, okay. Hi, Karen. I'm Joanna Protecka. I work as a pediatrician mainly in an ICU, but I also work as a community pediatrician in Vancouver. And Trail and Whitehorse.
Oh, wow.
Thank you.
there you go.
Great. I'm Nita Jane. I'm a pediatrician as well. I have been in practice for 15 years. It's hard to say that, in Vancouver. And I also work as one of the 4 pediatricians on the child protection team here at Children's Hospital. And so I've met a few people. I recognize Bernie from that clinic. And I see lots of kids, just like Elisa does, with behavioral and developmental difficulties as well.
Okay, so I'm Edmund Chan. I'm a pediatric allergist, and I work in the allergy clinic here at Children's Hospital. I've been in practice for coming up to 10 years now, and this issue is very, very big in our allergy clinic. We see anxious families that don't have allergy predominantly, it seems. And so that makes up at least half of what we see, trying to reassure them that they don't have allergy, but it's very difficult to reassure them because they're convinced that they do from all sorts of sides. And for those who genuinely have things like food allergy, there's a huge burden that the literature has written about, and we actually put on grand rounds in January, had a visiting colleague talk about that. And I was just saying to Nita recently, I just came back from a meeting of pediatric allergy interest section where we talked about these food bans at schools becoming extremely prevalent now, and wanting to ban more and more foods. So we just see it from so many directions.
Thanks, Edmund, because I had really no idea why an allergist was coming tonight. That's awesome. Thank you. Yeah.
Hi everyone, I'm Kim Corfusa and I'm the program manager with the Kelty Mental Health Resource Center at BC Children's Hospital. So we're a provincial information resource center for children, youth and families experiencing mental health and or substance use challenges. So thank you for having me here today.
So I'm Jane Garland, child psychiatrist, and actually I'm coming up to 25 years of practice, 20 of which I've also spent in the community as well as in the tertiary clinic, but currently I'm mainly at Children's Hospital tertiary clinic, which involves teaching, research, provincial planning, and seeing cases that actually are almost at a primary level for teaching purposes, like with our medical students, right through to the more complex cases. So I'm interested in all the issues and have worked with people in community mental health in here in Vancouver and in the schools over a number of years.
I'm Heather Louie. I'm a consultant pediatrician in the community. I've been in practice for 32 years. Okay.
I'm Barb Fitzgerald. I'm a developmental pediatrician, and I've been, I guess, in practice for 23 years. I did developmental pediatrics in the inner city schools for many, many years, and now I'm back at Sunny Hill. And more recently, I'm at Alderwood Child Family Center, replacing a child psychiatrist. So this is the second time in my career that I'm pretending to be a child psychiatrist. So I really was excited when I saw this come up tonight. And then I have a small private practice where I'm seeing kids and finally getting to follow kids after so many years at Sunny Hill of not being able to follow kids. So this is really relevant for me.
I'm Cedar Kunis. I've been in practice for 27 years. I was originally an emergency pediatrician. Things have changed, but having had to deal with anxiety, and God knows everything in the kitchen sink for all these years. And relevance of this is, well, it's affecting every aspect, both medically, physiologically, and everything in life. And it would be nice to be able to get some of the resources into this province that the other provinces have for this issue. So.
I'm Jane Finley. I'm a pediatrician with a background in infectious diseases.
I feel totally ill-prepared to deal with all these psych things. I'm convinced that anxiety is an infectious disease. I need all the help that I can get, so thank you very much.
But is there a vaccine?
It's called stress inoculation.
I'm Bernie Battle, and I'm with the Ministry of Children and Family Development. I'm on the intake and assessment team. So initially when we get calls from the pediatricians, it's like, how do we help this family? And that's kind of where I'm at, and I have a great interest in anxiety in children, primarily because I've been with the ministry for 34 years. And I've never seen so many kids in the last 10 with the anxiety that there is, and their families trying to deal with it. So I have an extremely sort of open kind of situation where I see the anxiety. It's how do we help these families? Because ultimately, at the end of the day, we want the anxiety not to be as high as it is.
My name is Tamara Van Wyck. I'm a school counselor with Vancouver School Board. And for the last year and a bit, I've been part of a multi-interdisciplinary team called MIST, multi-interdisciplinary support team, whereby we have a combination of school counselor, school psychologist, resource teacher, and speech and language pathologist dealing with cases that seem to bubble up beyond the school-based team capacity at the school in elementary and high school.
I'm Sandra Campbell, and I'm a school psychologist also with Vancouver School Board. And again, for the last year and a bit, I've been on the MIST team as well. So dealing with all of those students where they need more support than what would typically be expected to be given within the school setting.
And I'm Jillian Morgan, and I'm a school psychologist with the Vancouver School Board. And so like you, many of the children I see have anxiety, and so it's a big part of my work and their work, so we're happy to be here.
I'm Sriram Iyer. I'm a pediatrician based at Maple Ridge, and as the other pediatricians have mentioned, anxiety is a big proportion of our caseload, and we see that commonly even as comorbid conditions with ADHD, and also see anxiety manifesting, even amongst the hospital admissions, and so it's a big part of our practice.
I'm Trav Nguyen. I'm a general pediatrician and I work out of Richmond as well as with the Richer program here in Vancouver. And I also work with the cleft palate team and I'm a CA in oncology too.
And I'm Suman Jaswal. I'm with one of the community mental health teams. Been doing child and youth mental health as a clinician for about 10 years now. I recognize all names to faces tonight because we get a lot of referrals from community pediatricians, so it's really nice to see all of you in terms of working together with us in partnership and, recognizing to send those youth or children that you feel that need the support and knowing sort of the resources that are out there to help the families, because I think the resources are out there, but I think we need a forum like this to be able to share the information and the knowledge in terms of where to send these children, family, and youth in terms of to get that specialized service. So recently I've taken on the role as a coordinator at one of the community mental health teams in Vancouver. There's 3 main teams. Pacific Spirit, which is located in Kerrisdale. So that's the Kits and the South team have now merged into Pacific Spirit. So it's been about a year. So they've housed us in one center. And then the Northeast team, which is located more Hastings, and Nanaimo, kind of the PNE, so that's the other end of town. And then we have a team central right now is Midtown, which is the Raven Song community hub there, Main and Broadway.
Hi, I'm Aviva Lay Gindu, and I'm a cognitive behavioral therapist and in a local community clinic. We used to be CBT for kids, and as of last year we became LEAP Clinic, which is living effectively with anxiety and panic. And so with my colleagues, we specialize in treating children, teens, young adults, and also work with parents who are struggling with anxiety primarily. About 80% of our referrals are for anxiety. And so I'm very interested. We like to work, I'm trained as a school psychologist, and I like to work systemically, so it's neat to be here tonight where there's so many different people and coming from different places. So I'm happy to be here. Thank you.
I'm Sheila Anson, and I'm the second neonatal intensive care unit doctor here tonight, which makes no sense really, except that I also work in the neonatal follow-up clinic, and so I see our little preterm babies who are now grown up, and there is a higher rate of anxiety and depression in kids as they're getting older. And I also, through my own children, have interests in kids with hearing loss and with vision impairment. So.
Hi, I'm Svetlana Rozik. I'm one of the pediatricians, been working on oncology here at Children's Hospital, and 3 years ago I became a locum for Dr. Lipson, and during my residency I really hated all behavioral stuff, and then I was doing locum for her for 6 months, and she gave me all these cases, and now I'm there, so I really enjoy working with kids. And if I can help, I'm there, and you guys helping us a lot in the Thank you. And lots of oncology kids.
I'm Murthy Korada. I'm a pediatrician from Maple Ridge as well. Community pediatrician, we see lots of anxiety and other behavioral problems. One of the things that really strikes me is how little help we have in the community for all these kids, and sometimes we end up having to resort to medications, whereas some of these kids could have done better with some behavioral therapy or CBT and things like that. The wait list for mental health goes up and up every 6 months to 1 year. And it's really hard for these families, especially those who cannot afford a private psychologist or a counselor. We also do a pediatric diabetes clinic at Surrey Memorial Hospital. And as part of the chronic illness, there's a lot of anxiety that comes up with that. And the problem is people don't understand the chronic illness itself very well. And to do with anxiety as well as diabetes, it's very hard to get some kind of support in community. But these kids obviously have to cope, and families have to somehow get on with those problems and things. But hope there's some better solutions in the future. Thank you.
And I'm Julian Pladle-Pierce. I've been a paediatrician for a very long time, and I have a pension from the National Health Service to prove it. I trained originally as a paediatric oncologist, and I came to Canada 7 years ago to do something different. And I now do a large amount of developmental pediatrics, and I do a development clinic once a week in the Child Development Centre in Chilliwack. I tend to see anxiety as a bit like anemia. Anemia is a state of the blood that has an underlying cause, and I see anxiety as a state of the mind that has an underlying cause rather than a diagnosis. So I try and work hard to work out why people are anxious and what all the strands are, but I don't really feel I have any of the skills to help sort them out once I get that far. So that's one reason why I came today. I think it's great there's so many different people here. It's really awesome.
Hi, I'm Edgar Jimenez. Probably a new face to a lot of you. I detect that a lot of you already know each other in the room. Reason for that is that I did my residency in Winnipeg, and then I came to a subspecialty residency here in developmental pediatrics at Sunny Hill. So despite the fact that I was here, I was not here in no way. Having had that, I guess out of the way, I'm doing both general peds out in South Surrey, White Rock, and also doing some developmental FASD assessments out in Maple Ridge at the Asante Center. And so I see a lot of complex children and also youth justice teens. And in the clinic, despite the fact that I'm eager to general pediatrics to keep up those skills, there's a label that follows you. So I see a lot of development, behavior, anxiety, and anxiety is primary, secondary, or the tertiary issue in a lot of these children that I see with developmental, behavioral, or other psychosocial difficulties. So because I'm really not, I guess, even though I'm from here originally, but I didn't train here, I really don't know what community resources are available to me, so that's why I'm here.
Cheryl, do you want to introduce yourself?
My name's Cheryl Much, and I'm a community pediatrician. See lots of kids with anxiety, comorbid with ADHD and autism in my office. And my practice moved from Burnaby to Vancouver about 1.5 years ago now, so I'm interested to hear more about what's available here. I've certainly found that more of my patients in Vancouver have access to private resources than they did when I was working in Burnaby. So that's feel like I have a little bit more of a cushion to work with. All we had was Burnaby Mental Health there. But yeah, so I'm happy to be here. I was glad to find the room. Had some anxiety 20 minutes ago.
Thank you. And then we have a Penticton participant, Karen Lannon. Please tell us about yourself a little bit.
Well, I'm Karen Lannon, a pediatrician here, and just a comment to the technology person, if they could switch my view, because I'm just looking at the slide and not people. I think I'd prefer to look at the crowd. And you might find it weird that a pediatrician from outside of Vancouver wanted to be involved tonight, but I stopped doing on-call work as a general pediatrician a few years ago and moved into really community-based practice. And having lost that sort of infant toddler medical health piece, I have a huge middle childhood and adolescent mental health piece in my practice now. And I am constantly shocked by how poorly we're able to help these young people and their family. So I've gotten involved with our local child youth mental health team, although not very well, and I've been involved with the GP practice support program, and the GPs developing better educational objectives for all the GPs in the province, and that led me to be involved in the Child and Youth Mental Health Collaborative that's going on around the province. And I keep feeling like the pediatricians aren't being well recognized as having a large and useful role in this whole field of child youth mental health. It's almost like we're being overshadowed by everybody else. In fact, at the collaborative meeting in Kelowna just a few weeks ago, they talked about the various groups that are involved, and they said GPs and specialists. But there wasn't any clarification about who the specialists are. So is it adult mental health, adult psychiatrists, child psychiatrists, pediatricians? That piece needs to be broadened. And that's why I'm here tonight, because I think the BC Pediatric Society and all of us pediatricians should be having a big role in this one. And I think that's all I'm going to say.
Okay, thank you, thank you. Thanks, everyone. That was amazing. I mean, there's just unbelievable talent and experience and interest in this group. So honestly, we've done the really easy part. Saying 3 things about yourself, that's not difficult. Thinking about, you know, we're not going to be, this is not a CME on what anxiety is and how to treat it. It's really all of us trying to put our heads together and trying to help kids that are anxious. Choosing some cases was really daunting because you want to kind of have the perfect case who would need every resource that's here in the room. But there is no such case, at least not on my caseload. So, and I only have, you know, so many patients, but I thought we would at least try to focus our discussion about individual kids. So we don't have tons of time, and so I'm just going to present a couple of cases, and we'll see, you know, what people have to say about it. So the first 2 are kind of more straightforward. They're young school-aged kids, and they have a single anxiety diagnosis. And the older kids are a little bit more complex, as older kids tend to be. So we'll start with our first one. So this is little Jay, and he's in grade 1, and he won't go to school. Now, he was in kindergarten last year, of course, and he insisted that he have a parent with him at all times. And finally, parents bribed him with an Xbox for Christmas if he would let Dad leave for at least part of the day. So he was okay with that. And so he got his Xbox at Christmas, and he said, okay, I'm done. I'm not going back to school. So he didn't. And this family was fortunate to have the flexibility that Dad was able to stay home, and he did homeschooling, and it was called We're Too Cool for School. And they had a little room where he did his kindergarten stuff. So, I mean, he was pretty supported at home. So this is a kid that has always been with mom or dad. And actually, he's not a perfect angel, though bright and adorable in an office setting. He is full of tantrums. He's trying to control everything at home. His big brother is this lovely, patient child who is kind of abused by this little 6-year-old who wants his way at all times. So he was a little bit pram, 34 weeks. There were no problems. And so, you know, those who have the practice support program materials, we were given a number of quite useful things, and one of them is just a questionnaire called the SCARED, and there's a parent and a child one. So everyone in my office fills out a SCARED questionnaire, and big surprise, it was very positive for generalized anxiety disorder. You can kind of tally it all up if you want to take the time. Panic, separation anxiety, social anxiety, so he was positive for all of those. And then another screen for other psychiatric conditions, ADHD, etc. Really nothing else. And actually, he seems to be a very happy little guy. So the family history was surprisingly negative for anxiety disorders. Parents were totally calm and quite accepting of this child refusing to be in school. And when I interviewed him, I thought he was quite good at expressing himself. He said that his brother is violent, which was kind of interesting, because parents sort of said it was actually the other way around. And he eventually acknowledged that maybe he could be a little bit angry at times. And he said that when he is 10, he would consider going back to school. So that's little Jay. I think that was all about Jay. So this is a guy who has some anxiety, right? What are we supposed to do about this guy? And this is where you guys have to take it away. Please comment about this kid.
I have a question. I was at a brain developmental conference at the bar, not this summer, previous summer, in like 5 days, 7 to 7. And they had all these top psychiatrists, psychologists, pediatric neurologists, etc. from North America. Like these are the top guys.
Yes, yes.
Incredible.
Right.
So my question is, like,
Please
I'm
use
so
your mic.
bad with
Could you
names.
please,
Oh.
could you use your mic?
Okay, I'm always bad with names, but there was a lady in Montreal who developed an incredible thing for anxiety for school kids from kindergarten on up, and they were starting a program in Montreal. It was in French, but she was producing it in English across. And I have talked to a couple of teachers in some schools in the Lower Mainland, and they said that they are starting to use some of these methods in the kids from kindergarten on up to help with the kids that are very anxious. And some of these things are very simplistic. You know, it's sort of a little bit on the meditation,
Right, mindfulness.
Buddhist, whatever thing. And so my question is, why aren't all the schools on the bandwagon? Because it's been shown to be proved to work well. This lady's program is incredible. You got to read through this.
What's it called? Do you
Oh,
remember?
I'm going to have to look it up and go
Okay.
through my thing because I'm bad with names.
Okay.
And the thing is for all these kids with having their anxiety, especially with a lot of school issues and this and that, I mean, is there anyone doing anything in the Lower Mainland except for the odd school here or there? You know, kind of thing?
That is a great one.
So that, I would like
Yes, so that is clearly not a question for me, but thank you, wonderful, wonderful question.
kind of thing,
Okay, so
you know?
over to the school. Go for it.
So,
Please just say quickly who you are.
Tamara Vanwick, school counselor in Vancouver. We have a social emotional learning component that is part of the curriculum, and there are levels of the intervention, and the universals, which would be programs like Friends, Mind Up, which addresses the mindfulness that you referred to, Roots of Empathy. There are so many curriculums that are empirically validated and supported by our social emotional learning team from our school board that are in every school essentially. Now, every single teacher doesn't do every single curriculum.
So can you guys not allow access of this basic to the other people? Because I know all the teachers can't do every little aspect, but sort of the main key things that have been shown to work extremely well. And why is it a lot of schools, when you talk to the parents and the kids, they say, we don't get this. I know it's supposed to be in the school system, but none of them are getting it.
Okay, I'm going to just ask for, first of all, Heather wanted to say something, and then Jane.
At the risk of sounding
Could you put, are you on? Okay.
sounding heartless, this little boy was able to go to school to get an Xbox. So
Yes.
he's not terribly anxious all the time. He does have anxiety. So I mean, these parents need to sit down and say, Mommy goes to work, Daddy runs the house, your job is to go to school. This is not an optional issue. You know? And then all kinds of things can be done to help him. Like I sometimes found if you get a grandparent to drop the child off instead of the parent, or a neighbor and their child, you know, so that the fight doesn't happen between the parent and the child, that it's somebody else they have to deal with. and if the teacher meets them at the door. Like, there are many, many things that could be done. But what's in this history that's interesting to me is once the Xbox was on the table, he handled it. So he should handle it after Christmas, and I would not give him an
So
option.
this is more of a parenting issue
Yeah,
than
yeah,
an
yeah,
anxiety
yeah,
issue.
yeah. No, and they shouldn't have a too cool for school class at home. Come on, he's never going to go. Yeah, yeah.
Is that a clinical term, spoiled brat? I wish there was one.
I absolutely agree with that, but I wanted to say something more on the school thing. What I've noticed is parents, if you ask them, and kids, if you ask them whether they have the friends or the mind up, they'll say, no, we've never seen that, because it's exactly as it should be. It's sewn through the curriculum in a developmental way, because that's how children learn. And then in addition, kids who have special needs around anxiety, for example, social anxiety, may be pulled out into a Friends for Life group, small group. So a lot of it's happening, and parents don't even know. And I find that it's often, they talk to us, and then we give them the language and the questions to ask, and they find out, oh, wow, I didn't realize my kid is getting that. And that's as it should be, but I think we just need to be aware of that.
Is it happening outside the VSP, is what my question is.
It's happening in the French immersion schools now. It's happening in many of the private schools have taken on this stuff. But it's happening throughout the province, because it's available. Ministry of Education got behind this in the mental health plan starting in 2005. So there's been a progressive implementation of evidence-based programs, and they're sewn in developmentally, and the data is wonderful. So I think that part's dealt with. But again, I think this situation is a little bit different. There's a behavioral piece.
Okay, so we have Nita and Kelly and Aviva, and then, and yes, okay, please, go ahead.
Okay, just a couple of quick
And just
comments.
tell us quickly who you
Oh,
are.
Nita Jane, pediatrician. As a mother of a 7-year-old who was in grade 1 last year, I just wanted to point out two things. My daughter is in school in central Vancouver. She had a mindfulness program in kindergarten, and she would routinely come home and tell us how to all be mindful. Last year she did a program called Second Step, which I think is a social emotional program as well, which as a parent I just read all the notices and I managed to find out what it was, and I thought it was wonderful. I just had a comment about the case here that kind of echoes what Heather was saying. The two things that I found interesting in this history was that he had always been in his parents' company, and he was born 34 weeks gestation. And I was just curious how much that prematurity, I've had a 34-week-old as well, but just a different child, how much that plays into the anxiety that's created, that maybe we create to the parents, then that feeds off onto this very precious, fragile, delicate child who's always kept sheltered at home.
Right. That's a very nice point. Thank you. That's excellent. Yeah. Kelly, you wanted to say something?
I've only been out for 2 years, and most of that was spent on my maternity leave, so I'm still
Can you-
learning.
Can you speak into the thing? Thank you.
So I'm just wondering if every school has a counselor, like, or do you travel around to the different schools, or how do I access you? Because I have a kid just like this, but his mother has found some alternative school that tutors him one-on-one, and she asks me, well, can I just keep him in this type of school system for the rest of his academic career, or am I just enabling his anxiety, and I don't know what to say. She'd like him to go to public school, but I don't know how to access the resources, or whether there is a counselor that he can see at every single school, or the one that he goes to.
So Tamara's going to answer that.
So there is a counselor assigned to every school, part-time, based on the population. And that's mostly a formula related to the numbers, and a tiny component of that is related to the needs. So
Not every school has a physical counselor in the room, or in the school every day.
No one does. No single school has that.
No elementary school.
That's why you should give them more money.
Okay. Aviva?
Hi, I'm Aviva Legendu of LEAP Clinic, and I wanted to say, I guess first respond to the school-based programming. Having worked on school-based programming in various places, mostly local, but in local municipalities and also in BC, and actually my observation through our clinic is that kids kind of need a reminder to, sort of almost like a booster of what they already know. and they haven't necessarily generalized it. So that's one thing. Another thing is parents, I think it's dependent on schools as to what kind of information goes home. So I find even though kids go, oh yeah, I did that, and they can tell you all about it once you've reminded them, or they see the book in my office or something, lots of parents have no idea, and they'll just sit there open-mouthed, quite shocked, and then they'll start to hear about it, and they'll say, well, how come I didn't know, and is there a parent portion, or how can I be involved? So I think the other part is that I'm not sure if schools are consistently messaging parents or providing avenues for parents to get, when we did this, we had parent info nights, and sometimes they were really well attended. And sometimes it was abysmal on a rainy night in the fall. We'd have like 20 or 10 parents, 20 parents. But I see lots of parents who are really, really keen to get that information and who would love to be able to have that relayed to them. So that's, I guess, to that point. And then back to the case, I was going to say something similar in that lots of kids I find who are staying home, it's really cushy at home. They have the Two School for Cool program or something similar, often similarly named.
I think Dad's too cool for work.
Yeah, and Dad's at home, so why go? I mean, I don't see the motivation to, I think to go anywhere. And lots of times I think parents start off with really great intentions and like, let's follow a school schedule and quite regimented. And then as time goes on, they get caught up in the fun too, and kids are, playing Xbox and doing all kinds of other fun things. So I think lots of times it's around planning, around sort of having parents use that attachment in their relationship in more positive or sort of functional ways to help their child along, and often being able to step back so they can look at how can they weave that in a different way and still maintain a wonderful connection and all that lovely time. And then the other part is then making it less fun, and Dad going out, packing up, doing his work at a cafe so that there isn't anybody home, and coming up with a plan. So I see lots of kids like this. And I'm always very optimistic that they'll get back to school.
Right, thank you. And Suman, you were next.
I mean, very similar to what's been said in terms of this case. It's interesting in terms of like parents and of course their intentions with youth or their children that are struggling to get to school. It's painful to watch your child in that sort of that separation and that attachment. But what we find is that it becomes entrenched. Like the earlier that we target something like this has been going on for a year. And then this notion in therapy where we talk about rewards and, reinforcing positive behavior. Well, don't start off with an Xbox. Like maybe it's $1 so you can go to the dollar store. Like it's just the rewards, and then the focus is lost basically, because then of course it's a child, right? And if you're offering such a large reward for doing something, that behavior gets attached to the reward as opposed to sort of changing behavior so that child can function. And I echo the point. I mean, a lot of the work that we do is easing the parents' anxiety. And we do that quite humbly because parents are like, sometimes it's new, and sometimes there's a genetic component to anxiety in families. So at the team, what we do is when we get a cohort of kids like this, when we run our anxiety groups, we run a group for the kids and we run parallel a group for parents. So basically the kids and the parents are gaining the same information, and we'd be surprised. I mean, the energy that we've spent sort of with the parents far outlives some of the stuff that we're doing with the kids, because if we can ease their anxiety, it trickles down so they're not buying into like the avoidance and the school avoidance, because it's a big problem. And it becomes entrenched pretty quickly. So same thing, like, where do we intervene? What's the intervention? Who's your IP? Who's your identified patient? Sometimes it's the parent, right? And like I said, it's humbly sort of working through with them in terms of looking at their role in this.
Right. Thank you. I think I'm going to close it off after one more comment. I'm sorry, I don't know your name. No, sorry. Kim, I'm going to let you speak as well. Sorry. But the gentleman in the corner.
Edgar
and also, if Karen has something that she wants to add, please, Karen, let us know. I'm not sure how you can let us know. Can you let us know if you have a comment?
Oh, from Penticton?
Yes.
Yeah, we've, here I must say our child youth mental health team has developed a fairly good approach to anxiety in kids. So they actually do both a parent support group that directs anxiety in the parents, right? Which I think is a major contribution to some of the kids' symptoms. And then they do a group anxiety for education for the kids. And it seems fairly effective here in Penticton. So most of the kids here that we have anxiety get referred to our child youth mental health team for their programs.
Okay, that's very nice. Okay, sorry, it's your turn in the corner.
Edgar Jimenez, pediatrician. Just a comment about the case and from experience in the clinic. And one of the things that stands out as well is when I read negative family history of anxiety. And given the degree of the anxiety, you know, this can be true or cannot be true. We know that there's a large or at least a relatively significant familial component to this, like someone else was alluding to it earlier. And sometimes it's not until you dwell a little bit more into the actual family structure and or family history of parental behavior that you know, you get the faces from the parents as surprised that, oh yes, I guess I do have a little bit of anxiety. And I think that helps to bring them on board and helps to explain and they see the behavior of the child with another set of eyes, especially when I see a very young child come into the clinic with aggressive outburst of behavior, and it's perhaps because the child still does not have the developmental age or developmental abilities to communicate the state of anxiety that they're in. And that is, I find that that's a huge component when it's truly significant diagnosed anxiety. And so then my question is, especially in the area where I'm in, geographical area, you know, I'm left with, are there family-oriented for both child and parent support groups that they can access? Because many of these are mild enough that they can, at least with some follow-up and, you know, having a pediatrician quarterback the care, you know, can be managed in the community. So, but I really don't know if these are available.
Right. Okay, thank you. And Kim gets the last word.
I'll just say really quickly, so Kim with the Kelty Mental Health Resource Center, and this feeds into both what Suman was saying as well as the last comment about support for families. Something that we do at the Kelty Mental Health Resource Center is that we have peer support available for parents of kids with mental health challenges. And so the Kelty Center is somewhere that people can call from anywhere in the province, and the parents can get that kind of support that we're talking about around starting to help them understand some of the things that they may be doing totally well-meaning for their child, but that they may be doing that may be kind of enabling or allowing this child to continue in this behavior. And the fact that it comes from another parent who's been there, who's been through this themselves, it really comes from a place of non-judgment. It comes from a place of understanding, and the stigma and some of the blame is really alleviated in that way. So to answer your question, that's one way that they can connect. And the organization that we partner with, the Force Society for Kids Mental Health, has parent peer support workers all across BC in different communities everywhere that can actually meet with families face to face and you know, talk them through some of these things and help connect them in with, you know, support groups or local resources that are available. And those parent support workers are very, very knowledgeable about the mental health care system. They've been through it themselves, and they really get it. So so just to put that out there as a resource that I think is really great for parents.
Okay, thank you. So I think I'm going to try and summarize this, and I would invite you to help me do that summary piece. So we have a child who was born prematurely, perhaps set up for parents being worried because he was premature, even though he sailed through without any difficulties. And so they are, let's say, with him at all times, and they actually really enjoy being around him. But it turns out that he is actually a bit of a tyrant, and he isn't that much fun to be around all the time, and certainly for his older brother, and parents really don't know why. So when we ask them specific questions, is your child anxious? Yes, they say he is. He's highly anxious and he has panic and all kinds of features of anxiety. In addition, he's decided that he doesn't want to go to school because being at home is really so much more fun. And he has dad one-on-one giving him this wonderful school experience. So what we can say to the parent is that, well, this kid should be in school. Now, they may like that or not, because there are some deep issues that aren't going to be fixable in the pediatrician's office easily. And let's not forget, he does have features of anxiety too. But we can work on that insight with the family. We can also tell them that actually there's a curriculum in school for social emotional development. It's there. Your child will learn some skills, correct? That maybe not his own teacher, but it's part of the curriculum that many teachers have. Now, whether he would get it, we don't know. But then there's the other part that how the heck are parents even going to know what the curriculum is? Because most parents don't know. I mean, I don't know, and you find out because you're a parent and your child brings it home. But so there's this sort of treasure in the school that's happening that nobody seems to even know about that could actually help this child. So what else did I want to say? And actually, as the last speaker said, there may be some anxiety in parents that they are not really acknowledging. And if this kind of formulation is correct, then they probably do have quite a bit of anxiety about their child, at least in some sense. I think they're also very much enjoying him, even though he is a tyrant. So I would just ask you to, and I don't want to spend longer on this case, but you know, I mean, Heather may have the skills to get this kid back into school. I don't think I have the skills to get this kid back in school. And so I would ask you, I mean, you know, there's some basic principles, don't make it so much fun, and really clarify things for parents about really how this has played itself out in the family that they don't really want. They're smart people and they want the best for their child. Maybe if there's some other suggestions specifically for this kid in Vancouver for dealing with the situation, I would like a couple of suggestions. Heather.
I would think that the role of the parent is key, and I think my own experience is with school phobia of any kind, that if the parents make it clear that this is what they expect, you know, that if both parents sit down together and say, this is over, I would say 75% of them end up back in school. And then there are 25% that really do have sufficient anxiety that they need something more. But I think exactly, this father is happy really to have this child at home, and that is the problem, you know.
I've just been cruising through the Anxiety BC website, and they actually have quite a large resource document list that helps with school anxiety, like the fear of going back to school. So that's another tool that you can use in your office with the parent to go through some of these easy to access resources online through Anxiety BC. And a lot of it's pretty straightforward, you know, good parenting, being consistent, setting up the expectations, if that's helpful to anyone.
There was one more comment.
Just in terms of just basic anxiety principles like gradual exposure, right? Gradual integration back into, because this is entrenched now, right? It's going to be very difficult, and it's easing the parent's anxiety to let that kid tantrum or whatever's going to happen, and having the school support them on the other end. So if there's, you know, a teacher or a peer support worker or somebody in the school that can reintegrate this child back in, because it's not going to be that easy, as we know.
No, it's not going to be easy. I mean,
it isn't.
We can say it's going to be easy, but, and you know, Heather, I'll send them to you. But I'll let you know the next time how things turn out. And I should have also brought in your comment that they can call Kelty and get set up with a family that's been there, right? I mean, that's the thing that happens. You phone up and you say, I got this problem, and then you guys find them a parent.
Yeah, so through our partnership with the Force, exactly, we'll set them up with a parent in their community. If there's no parent in their particular community in BC, then the Kelty Center is the provincial resource, so they can call us. It's a toll-free number. Anyone can access from anywhere. It's very low barrier,
Right.
and yeah, you don't need a referral or anything.
Yeah, okay. You know, Barb, I'll let you make a quick comment, but I want to move
Very
on.
quick.
Okay.
I just wanted to say, I think we all know that there's so many wait lists for many of these services, and I think with someone like this, I really hope that we could manage this ourselves, because I think one piece that we haven't brought up is these parents need to have a trusting relationship with the person who's caring for them. And if they know you, and you say, I know you can do this and I know your child can do it, I think I just see so many kids at Sunny Hill and at Alderwood who have been referred to 18 different resources in Vancouver, but they don't have a relationship with any of those people. They have a relationship with their general pediatrician. And so don't underestimate yourself just because you think you haven't got a child psychiatry residency.
Have to move on because, but we may only get through the second case. Hold on. Okay. Let's go to case 2. So this is Anna. She's also in grade 1. So this is a girl who will not speak in school. And, you know, this is a kid who actually started to talk at the beginning of kindergarten, and then she became increasingly silent. By the end of the year, she would not speak to anybody. And at the beginning of grade 1, she whispered to her last year's teacher about what she did in the summer, and that was it. I saw this child kind of in March of her grade 1 year, so there was no talking, a nil verbal output. She likes school, and as she approaches school, Mom walks her there every day. She kind of grabs Mom's hand very tight. But she goes happily, and she had a best friend who was in the other class, and she plays with her old friends at recess. When her mom is in the community and she goes to the grocery store, she will actually chat with Mom when they're physically in the store. As soon as another person approaches them, the child totally shuts down and won't say a thing. So she loves to go on play dates. She goes to birthday parties. When friends come over to her house, she does not speak. When she goes to someone else's house, she does not speak. It's amazing what a great playmate you can be and not say a word. So she does fine academically, so long as she doesn't have to say anything. She doesn't read aloud, of course, but she does do some writing. And Mom noticed that when she was in her after-school care last year, there were children of different ages, so she was not really playing much with them. Mom then would pick her up after school and take her to work, and she would make tea for people, and she'd sit and do her homework, and she was wonderfully helpful and adorable. So while I interviewed Mom, she listened very attentively, and I got her to do some motor tasks, and she was completely cooperative, and she loved doing everything. And she nodded her head, and she showed me, how many fingers with how many siblings and all that. And I got her to do a little task of this, and rather than do it herself, she grabbed her mother's hand and got her mother to do it, which was kind of odd, but she's not autistic. She separated easily from her mother. I mean, she's not a kid who has, she goes to sleep fine at night. She's not scared of other things. She just won't speak. So that's case number 2. So please comment on that.
I'm going to have to comment first because we actually have a revolutionary new treatment for this, which is 1950s behavioral treatment for this phobia of speaking. And we actually have a research project that's starting now. So right now, we want to see all the selective mutisms in the province. And we're seeing them by telehealth, and we're seeing them by whatever at our clinic, because we're really refining this protocol and doing more and more outreach to teach the clinicians in various parts of the province. So this is easy. Send her to us.
Okay.
No.
So actually, I have a comment back to that. Jean.
Yeah, okay.
Because I happened to be doing my homework this afternoon in preparation for this, and I was speaking, was it the I had mentioned her name,
Noelle or?
no, I think it was Noelle. Yes, we were talking about groups and all that. So she told me exactly the same thing, and I think we heard about this, if anyone was at the BC Pediatric conference.
Right.
That was
From Annie Simpson.
recently, and we heard from Dr. Simpson, who told us this wonderful approach, and selective mutism, we've got that. But I spoke with Noelle, and I said, oh, Noelle, it's so great that you have this. I'm gonna go through my files, and then the last year, I'm gonna send everyone to, no, don't do that.
But in fact, we do want to see them because we're doing.
Even if they've seen Dr. Catchpole or the.
No. If Dr. Catchpole is the one who's doing the large part of it. So they've seen Annie or Dr. Catchpole. If they're getting treatment, great. If they're progressing, great. And the approach is just very simple. It relates to our first case as well that we just discussed. It becomes an established behavioral pattern of not speaking. There was anxiety. There was an escape. It worked. And it isn't just the child. Everybody else is less anxious because the pressure was up with this anxious child, and it becomes a habitual thing. So that the training is really a behavioral treatment, making the steps small enough, which isn't easy. It's very systematic. I think Peter McLean used to say behavioral therapy is not rocket science. It's not rocket science, but it's meticulous. Step by step by step by step, gradual exposure. It could even be done by paper clips. They're whispering to the parent, and you get this line of paper clips, so they're whispering a little bit louder to the parent. Or we have them speak to the parent out on the picnic table and gradually come closer to the building. And it really is very behavioral, very systematic. And we would like to see as many of these kids as possible because many of them will qualify for a research project where we're going to be the place that establishes the research base for this. When we know it works because it's being used elsewhere, but nobody's been researching it systematically.
Okay, well, I will send all my cases here.
Yeah.
And yes, the school folks have some things to say.
To speak to that, we're following Dr. Catchpole and Dr. Simpson.
Right.
They had done some outreach to some of our inner city schools. So after all of our comprehensive notes from their education to us, I think our big piece is debunking myths within the school staff particularly. There's a lot of storytelling that happens and potential pathologizing about they've probably had trauma or there must be a family secret or something like that. So school counselors do a lot of inter-staff work around that.
Yes, Svetlana.
I have just a comment. I saw a similar case like a few years ago, actually 2 years ago. A child was with selective mutism, and mom questioned me because mom was on methadone and she was drug user, and she thought maybe because child was on morphine for some long time and she experienced some trauma when mom was like kind of coding and having like drug abuse, and was it like post-traumatic stress, and that's why she became selective mutism. And then I sent her to psychiatry, and Dr. Golden was excellent psychiatrist who dealt with her, and she even go to school with her, and she had her CBT approach. But now, and kids start speaking after 2 years, being homeschooled, now she's at school. But I'm not sure who did provide her with a dog. There was a dog that the child actually now has. I don't know, like, is it like from your team? And now she has a little dog, and she's going to school, and she's talking to dog, and through the dog, she's talking to other people. I was so amazed. So I don't know, do you guys have that type of approach, or you're not providing dogs, but
great story.
Real little dog.
They'll talk about her patients who, believe me, were way overboard, and I convinced everybody to let them have a dog. There are a few dog groups in the Lower Mainland, and not just dogs.
And it's amazing how a dog attached to a child with major problems smooths everything over like no tomorrow.
So they're allowed in the school?
Yeah, the school will allow it if you write a medical certificate or a note for it. And it's amazing how it works.
Yeah, I think especially trained, right?
Oh, the dogs are specially trained through these groups, but they're not expensive like the CNIB dogs. But there's about 4 groups in the Lower Mainland where the dogs are trained for different purposes and not just blind or motor, but for things like anxiety and behavioral issues, and it works great.
Can I ask a question?
Sure.
Just like Jane or anyone, I mean, I guess just playing devil's advocate a bit. I mean, if we look at, you know, when does something become a disorder? And this child is happily going to school. She is playing with friends, having friends over to play. She's meeting academic expectations. Isn't she going to talk when it serves her well to talk?
What we know from the research is that there's been quite a bit of observational research on these kids. And certainly a kid who's in grade 1, if there's a progression of talking, maybe by the end of grade 1 it will be better, particularly if they build on the positive relationship. The problem is if you go into grade 2 and halfway through grade 2 and go into grade 3, you now have a habit pattern where the other kids talk for the child. The child is now off the hook, you know, from talking, and it becomes a habit. And we see 11, 12, and 13-year-olds who have never spoken outside the home, and that is very developmentally disabled. So what we do is we see, you know, are things progressing or not? Right? So
I guess that's slightly different though, isn't it? Because a 12-year-old who doesn't have, they wouldn't have friends, right?
They do.
Yeah,
they do.
Amazing. Yeah,
They
it's
do.
amazing. It's amazing, actually. So it just teaches you that, you know, not having speech doesn't mean that you can have things. I just going to ask people to put their hands up, because some people, I think Heather was next, and then Aviva. Did you?
I just want to say I found this much harder to treat than school phobia,
Right.
and probably because kids with school phobia come to us sooner. You know that it's unacceptable that a child isn't attending school,
Right.
but a child cannot speak in school for several years.
Yes.
And I agree, everybody accommodates, and then it's almost impossible to get the child to speak. They often have a best friend who speaks for them.
Right.
And so I don't feel in this situation that I have been able to get a child to speak without getting them to see someone like Annie Simpson and learn brave talking. You know, she does such a good job. And they often have to move out of the school they're in because they have a whole group of people who support their weakness. So I just think this is a very challenging thing.
Aviva, you wanted to say something?
I was going to say something about a couple of free resources that parents find helpful. And so one is there's a regional coordinator through the Child Anxiety Network. There's a selective mutism group, which is American, but they have a regional coordinator who's a parent of a child with selective mutism who I think has been now successfully treated and is doing well. And so she coordinates, and I think she's on Kelty, Darylyn, and so she provides, I mean, she'll be a parent contact and talk to people over the phone, but they also run a monthly, or they have in the past run a monthly support group, which lots of parents have gone and found it to be quite helpful. And then there's offshoot friendships, and they get the kids together, and so they're working on similar steps sort of in their behavioral plan, so that's helpful. And another one is there's a book that
Excuse me, is that like an online group? People can participate?
It's not.
No,
I don't think
it's
it's been
not.
online so far. They varied it from municipalities. So I think they've been in Vancouver, Richmond,
Oh, I see.
Burnaby. So they
Okay.
kind of Maple Ridge, I think. So they've traveled around.
Contact Kelty.
Yeah.
Okay, Kelty's the.
You have that. So, and you know about that. Yeah. Great.
And I guess, and there's two more quick ones. One is parents on the Child Mind Institute, which is a New York place, and I think the person who does the Brave Buddies and the selective mutism programming are the people but they have these, they have on Ustream, they have these talks for parents on selective mutism, and so they have some where they have kids who have been treated who are talking. I think it's called Hearing Our Voices. And then they have a bunch of other ones with different, I think they have SLPs and psychologists and neuropsych and a bunch of different sort of multidisciplinary team members talk about selective mutism, and they talk about how do you approach the holidays, what to do over the summer, how do you set up play dates, like what do you do? And so parents find them, I think they're usually around an hour long, but they're free, so you can just go on there on their channel and watch them. And then they're free and accessible, and they're some of the technical aspects of the videos are a couple of them they vary in their quality, but in general they're pretty good.
And then by the way, we're going to send all of this information out, so you don't have to totally get it all down. No, we will collect it, right?
And then there's one more
I have
book.
Okay,
There's
sorry, go ahead, carry on.
There's a book.
That's why I'm not drinking wine. Can I give you another coffee?
There's a book by Dr. Angela McColm, who's in Ontario, and it's called Helping Your Child with Selective Mutism.
And then she has this companion list of forms which you can get for parents, and they're great, like if you're working with a school team, because they can kind of look through the day, and so which parts of the day is a child experiencing more anxiety with, and which situations, because it kind of, you have to be so systematic, so it breaks down all these, do they talk in this situation, that situation, this time of day, so it's sort of a matrix. And you can get that from her book, but she also has this companion list, and that one's, I think at Kelty, I know it's in the Vancouver Public Library, and it's also pretty cheap. Sorry, yeah, so that's a good resource too.
Right, okay, thank you, that's awesome, yes.
So I have a question for the school, because I wonder, just to clarify, who is diagnosing the kids for your counselors? So for example, selective mutism is actually simple. If they do not talk to you for a month, we'll figure this out. But with the anxiety and some other behavioral issues, it's just a teacher who is telling your counselor, listen, there is something wrong with this kid, can you figure this out? Or you sending them to pediatrician or sending them somewhere before the counselors start to approach them into some kind of systematic fashion?
We don't have to wait for a diagnosis from an outside agency or community partner before we start working with the child. Parent consent would be our only barrier there. We start working with what their level of functioning, what the presenting behaviors would be. No one in the school system would diagnose an anxiety disorder. School psychologists diagnose, but completely different things.
So how kids can approach or you involve any of your counselors?
A lot of organic referral happens, especially in elementary schools, by the teachers talking to the counselors. The counselors are in the hallways and in the classrooms, seeing the children, seeing the parents drop off. We're at a school between 1 and 3, maybe 4 days a week. There's only a couple of schools that get 4-day-a-week counselors, but we see everything with our own eyes.
And then the counselor deciding who's going to what kind of program, or?
We have what's called a school-based team. So the resource teacher, administrator, classroom teacher, school psychologist, area counselor, speech and language pathologist meet every 2 to 4 weeks, and discuss the highest priority needs at the school for academic, social, and emotional, and for the behavioral needs as well. So it's triaged in a sense from that point. And counselors have some autonomy as to whether they are, see a lot of individual or small groups or full class or do parent work. So it does vary through every school.
Okay, I'm just gonna, oh yes, please, go ahead. Yeah.
And I was gonna say that, so we all work on the school-based team together. So there are times where someone will say, well, why don't you have a look at the child? So as part of my role as school psychologist, I'll do that. Or if I'm doing an assessment, because there's a lot of comorbid things happening for that kid, I might do some anxiety screeners as well. And then we might talk about those back at school-based team. And we might refer on to you, to pediatricians, to people in the community. But yeah, we try and do a number of things just at the school level to try and tease out what's going on for that kid.
So if the child will get a diagnosis from us, the pediatrician, let's say, of anxiety, is that going to help you out to streamline their behavioral treatment?
Technically what it does is it would provide funding related to a designation for that child. You've probably heard of an H designation.
And
so that would give,
funding?
well, $9,000 to the school district, which gets the special education, which gets the support worker, goes into the support worker fund. And then its support workers are issued on a per needs basis. It does not mean that that child will have a support worker for any one-to-one.
Right.
And not every child that receives a diagnosis of anxiety would necessarily qualify for a designation
Okay.
that would lead to that funding. There also has to be things happening within the school. It has to be impacting in the school and impacting academically. But there has to be evidence of that, and there has to be evidence that.
So
What about this child?
Just one second. Would this child then qualify?
Probably
No,
not.
okay, sorry.
Yeah.
So
Unless she
who's-
has ongoing community support. If she's weekly or bi-weekly seeing a community therapist, then it's possible.
So if there is a committee who's making the final.
For the,
Are you referring to school-based team?
No, for
decision
designation.
to make a designation?
Yeah, there's, it's, depending on what designation is being requested, there are different people at the district level that look at that and decide whether that student fits the criteria that the Ministry of Education has set out for that designation.
The school applied.
Okay, I just want to, there's a few people that have indicated they want to speak, so Susan can go next, and then Dr. Carter.
Yeah, that's where a lot of the interface happens with the community mental health teams, right? So if there's something happening at the school level, a child is identified, they refer it to a community mental health team, right?
School will.
Or refer it to us. Yeah, so we get our referrals from community, like, you know, directly from pediatricians, from family doctors, from school, from, you know, teacher, whoever, right, in the community. And basically that's where the assessment, then we have psychiatrists and pediatricians on our team. Like right now, we have a pediatrician actually that we're fortunate to work with a couple of sessions a week, and not everywhere, that's what I'm saying. And we have psychiatry, so we have a psychiatrist that is on our team and available for consultation. So basically we'll screen, I mean, they'll do the first screen in terms of the milder kind of cases, and those aren't the cases that we're capable of taking. We take the more moderate and severe, and we do a full assessment of that youth, right? And the piece that we don't do is the psychological assessments. Then we'll go back to the school and work in partnership with the school to get a psych ed done if they need that too.
5 years.
Okay.
Yeah.
Well,
that's why they need more money.
So Dr. Plato-Pierce is next.
I was going to say that I think there was interesting reflection on the, you know, who makes the diagnosis and so on, and because I think that as pediatricians we need to be proactive about engaging with other people and other services. I go to a lot of school-based team meetings to talk about the kids that I see in the clinic. I go and observe a lot of kids in classrooms. I've observed kids in every single elementary school in my school district, because I've never believed you can do developmental pediatrics by sitting in an office. And that way you engage, every time you go to a school and you discuss all these issues with them, you engage with them, you get supportive working relationships with them, you can begin to put some of your ideas across, and it begins to make a difference in the schools which you go to. So I encourage people, rather than to stay separate and only meet when you come to a meeting on Thursday evening, to actually go out to schools and see what happens in the real world, because I think it improves your day-to-day practice.
Okay, Kelly, you can finish.
Just quickly, are those designations the ones from A to H that you read? Okay, and so am I, and maybe going to be embarrassed by saying this out loud, but I was under the impression that I can't diagnose certain things and get those designations. Is anxiety one of those things that I can get a designation for? Like for FASD, I didn't think I could do that. I had to go through Sunnyvale, or through autism, obviously I have to go through Sunnyvale. Like what things can I get designations for? Is there like a list I can look at?
The regulations actually say that it has to be a multidisciplinary team. So, for instance, I've managed to get sort of chronic health designations for kids I've seen in the Child Development Centre, because I see them together with the occupational therapist and the physio and the speech therapist and all the rest of it. We do a detailed discharge summary from all of us.
Okay, you know what, I'm going to just interrupt here. The reason I'm interrupting is because it's a huge topic, how people get designated, and it is honestly worth a whole session, and something that everyone is very interested in dealing with. So let's save that for another session. That discussion is really, really important, that everyone would like to, I'm sure, share ideas about that. So I'm just going to try and summarize this case a little bit. And so this is a child who has pretty easy to recognize selective mutism. We have this wonderful new answer to our children with this disorder, because we can send everyone in BC to BC Children's, and I can tell you that that is the case because I had a child from Bella Bella, BC, a tiny community on the coast, and when I spoke with Noelle today, she said she was just speaking to the parent of this child, and they are going to do an amazing thing with this patient. This family is going to come down for a week, and they're going to do an intensive assessment and start the treatment. So it is really going to happen. I kind of got the impression that there's a capacity, but Jane is saying, just send them all in for now.
And I would just say with that, that it will turn out that a fair number of them can be dealt with some of the other things that have been talked about, with the parent advice and those things. So they may not all need to be seen, but the ones who are paralyzed.
Okay, and thank you for that, because there are other things that we can do beforehand. So there's some good resources that are available online for parents and just education about what they can do. And I would have to agree with Heather that if you've tried those things, you're going to have to move on to something more. And so you'll have to get some type of therapy for this patient. And that the schools are already identifying them, obviously, and sending them on. And it's kind of nice to know that we do have that resource available to us. Okay, did I kind of was there something I missed? Okay, so it's kind of late and hot in here, and we have coffee and dessert. I have 2 more cases. These were the easy ones. The other one's a little bit more, but I'm going to just ask for, the other thing I wanted to do is have our panel say a little bit more about what they do and how we can work together in a general way if they have the energy for that. Bernie, I know that the cases we've had haven't really been in your realm of Ministry of Children and Families.
Well, in terms of the parenting piece, yes.
Okay, so maybe you could talk about that then.
Like in the beginning where we said that it sounded like the parents couldn't get the kid to school. Well, you know, a lot of that is giving parents the encouragement that you have to parent this child. And if they don't have that confidence in their parenting skills, we run a program where parents can phone us and ask for support services. And
this is your Ministry of Children and Families, right? And parents can call you directly?
They can call us directly.
Okay.
And we would assess the situation. And if they're looking for support, and we think it's a parenting issue and they're looking for parenting support, we have a few programs that run. We have our family preservation program, and it's an awesome program. We have a worker that would go into the home and work with the parents and watch them with the child and give them some tips and ideas on how to work with that child.
You mean so these parents could phone up and say, I've heard I can access this program. They're going to get someone to come in and support their parenting at home?
They're not going to have to leave the message and wait for 3 years to get their message back?
Not 3 years. They may have to wait a while till we get a worker. They would go on a wait list.
But somebody will call them back and let them know?
We would immediately call them back. Like, I have to say, our screeners are pretty good in our certainly in the area I work in. We have 3 screeners that screen calls. And if a parent phones and says, I need support, and we have a worker on each of our intake teams that actually will call the parent and give them different strategies or different ideas on what might be helpful to them. So if they get a situation where they're saying, I really need some parenting support and I'm looking at how to get it, and their child from the age of infant to 12, then we look at the family preservation program. If it's a child where they're 13 and up, then we look at our self-van use services program. And so we do parent mediation, we do parenting skills work with the families.
Well, that's actually wonderful to know. I didn't know that, so that's awesome.
So there is a specific number where parents can call instead of major
depending on the areas that they live in. So if it's in the Vancouver area, north or south, the number they call is the 660 kids number. and they ask for a screener. They ask for a social worker, that they'll ask them for their address, and then they give them to the screener that's in their area.
But after hours, it does not
No.
work.
Right. No,
Well,
after
it's
hours
not
won't
first,
work,
it's
because
six.
it's not after hours that's gonna go out, it's gonna be a district office that's gonna go out.
But it doesn't mean their child's gonna be apprehended or.
No.
No, that's of course what they're worried about, right?
And
Yeah.
it's-
That word
and I
protection
think
is a
that
nasty word.
The word protection, and I think that what we have to do more of is to try and encourage families. We're here to support families. We very rarely take kids away from their families. That's not we need to work collaboratively with kids and their families. And parents, we all know that parents are ultimately the best place for kids. But parents don't necessarily have the skills that they need to parent that child. And when you've got kids with anxiety disorders, who has the skills to deal with a child with an anxiety disorder as a parent? It's learning skills. And where do you get the information to learn how to parent that kind of a child?
What should we do if we have parents, because I'm sure probably everybody's had this example where you have a parent who says, I did call in, I said I'm at my wit's end, and they said, sorry, this is not a protection issue and we don't have staff for you. Because that's been my experience.
What we need to do is say, I'm looking for support. I know there's some areas where they simply can't do the support piece. But for the most part, even if they can't, they can phone Family Services of Greater Vancouver. They have counselors there, and they do prorate, and they do prorate. So if it's a family that can't afford, they can get counseling services through Family Services of Greater Vancouver. There are a number of different resources. So we also have a family day program for parents who really are struggling to parent their children. And I think that I've seen, as I say, I've been around a long time and I've been in the Vancouver area for most of my career. I've never seen as many kids with anxiety, and I think overall we have to look at why are these kids suddenly so anxious and what's really happening there. And I think that the doctor over there that said, like, really, what are we doing with these kids? It's a state of mind with underlying causes. A lot of these kids are anxious because their parents are anxious. They're afraid to parent their kids because a social worker might get called. But we don't want them to be afraid to parent their kids. We need them to parent these kids.
But I have to say, I would have to agree that the word protection, unfortunately, is a huge barrier. We need a different word. So just on that note, I'm just going to suggest that maybe we can have a show of hands. How about if we have just like a 2-minute break and everyone go get coffee and dessert, and then we'll wind up? Or if you need to leave now, you're welcome to leave. Okay, so is that okay with everyone? Because it's kind of hot and it's been, yeah, okay.
You want to extend until what time? Yeah, I already done 9, but we do have a break right now. You only going to talk like 15 minutes. It's up to you. If you want 1 to 10, it's 10. I already extended to 9, so okay. And are you going to use the PowerPoint anymore, or just more just talking?
I think, is it okay if I use it? I wanted to.
That's fine.
What, summing up, okay, what do you want to say to the group?
Yeah. Okay, I will leave the PowerPoint. Yeah, that's fine. We'll do that.
Oh, wait, sorry, it's whiteboard. Whiteboard camera. Yeah, no, definitely, but I don't need to bloody
Thank
Evaluation forms before you leave. Please fill in the evaluation forms. It's our requirement. So we really appreciate your feedback.
I think I know, I can tell you who went, I really want.
It's amazing.
I'm never get hurt easily.
So we'll see you next week. I know that no boundaries. I
Hi, everyone. Hello. I think we're going to resume. And I promise, this clock says 8:45. We're going to be out in 15 minutes, okay? But maybe nobody wants to. Does anyone want to resume? Okay, so you know what? Maybe people can be seated again. Have your coffee and your sweets. And we really are just going to be a few more minutes. So I had a few questions that I wanted to ask everyone, and maybe we don't need to do them. So summing up, what issues have emerged? We're not going to talk about that. Does anybody want to talk about that? I think we kind of know what issues have emerged. What should we do about it? What are the gaps? How can we use each other's resources better? I don't know the answers to those. I think it requires some thinking. Maybe people can think about it and write something about that. But what I really wanted to do in this last little bit is give our panel, in quotes, an opportunity to just tell us, pediatricians, about their work and about whatever they want to tell us that hasn't come up yet. So I'm going to start with Jill, if you don't mind, Jill. Okay, so Jill, please just remind us your job, and then just please, if you have nothing to tell us, then that's fine. But if there's something that you would like to tell pediatricians, we are all ears.
So I'm Jillian Morgan. I'm a certified school psychologist with the BSB. So I know a lot of you by report, not by ever meeting you, but you know, I really do feel like we do work together on some level. It would be great to have a closer relationship where we can actually have some phone conversations at times, because that has been helpful with other professionals that we work with, because we do feel a bit isolated, and we often feel that when we send parents to pediatricians, they don't often get there, and so sometimes we need some support in that way. I do find that when I see students for learning, you know, it's for a learning referral, learning disability potentially, that there often is anxiety as a piece of that, and sometimes by simply putting that into writing in my report, I can move that parent along to getting some help for that child, because I often see that as sometimes the more important piece to what's going on for that child. So you are really like my first line of where I refer to our pediatricians in the community, because I can actually get a child in to a pediatrician within months, whereas other resources, it seems to take a lot longer.
Right.
So
I'm just going to ask pediatricians here, who here is open to email contact from schools?
From school? Yeah.
From schools?
Not from parents.
Yeah, not from parents, from schools. Like to get an email from, because a phone conversation is next to impossible. And sometimes, you know, like email has major limitations, I would say. Yeah, in one moment.
Can I just suggest from my experience, actually phone conversation is very useful, especially if you schedule it in your daily schedule as to where you want, you know, you can actually fix an appointment, a telephone appointment with the school, and it really works well. That's what I find. But
you know what?
again,
it's a wonderful idea. It's a wonderful idea to put it into your schedule. We actually get paid. Pediatricians do get paid for phone consultation that is booked ahead with the school. It's called the Pediatric Case Conference, and it is used to be that you had to do it in person. Now a telephone conversation is actually acceptable. That's just for us pediatricians. And so if you want to do that, I personally prefer to have these conversations generally in the evening, and sometimes teachers aren't all that keen for that. For me, I'm not able to say I'm going to be there at 3:45 on Tuesday. It's just not going to happen. But it might happen at 9 a.m. on Tuesday before I get bogged down with patients. But I think that's a wonderful way to do things, is to put it in your schedule, because an email is one thing, and I often use email to set something up, and then you are not playing telephone tag, because there's nothing worse, drives me absolutely nuts to play telephone tag. But sometimes actually you just, so I have a new thing in my office. I have two new things. I have a computer screen, and I can show parents stuff, and I have a phone in my office, and I phone out, and sometimes if I call at 3:15, I can talk to the parent, and I mean to the teacher right then and there, which is really a wonderful thing. So it's true that if you call at the right time, you can also reach people.
And I would say email is best for us, because VSB itinerants just have voicemail.
Right.
So it is best to set it up by email and then actually have a phone conference. So.
So I have a question. Years ago, the VSB used to have a booklet which made life easy for us, where we could look at this school, see who the principal was, the vice principal, the psychologist may be attached, everybody down the line. And nowadays, even when you talk to the teachers at a lot of schools, they don't know who the name is. And one of the schools said, well, I know a few schools have given me consistently that they say, well, there's only about 19 psychologists for the whole lower mainland for elementary school level things. We don't know, you know, and, you know, it takes hours to hunt someone down for putting in emergent, really serious request of getting either, you know, please, can you please do this psych ed test within a year before they hit high school, because I know this kid has X, Y, and Z, but I need the food for the support and whatever. And the thing is there's no contact list. So we can't even email you.
But I think I'm hearing that there is.
There is.
But it's
Yeah.
not easily accessible.
Well, no, we will send it to
Okay.
Elisa,
Yeah,
and she
okay.
can send it out to all
We
of
will-
you.
Yeah, because it's
Okay.
gonna be on the minutes from tonight that everyone will get. All these great resources that have been mentioned are going to be there.
Okay, great.
So we will get that to you.
But is there one for the other schools and the other school boards? Because
I'm sure there is, but someone has to do that.
But
Yeah,
some of the
yeah,
other schools
No, I know.
boards are hopeless, especially.
Okay, well, you know what, I'm going to ask Stephanie about that's a
Okay.
special request, okay?
Yeah.
And, you know, I'm just gonna say one other thing, I should have, before I forget, that another really key player here is Anxiety BC, but unfortunately, the executive director was not able to be here tonight, so she emailed us this afternoon. So I know that it's a shame, because I'm sure she would have really added to our conversation. Yes, go ahead.
Sorry, I was just gonna say, when it comes to finding out who the school psychologist is in the school, sometimes the teacher is not the best person to ask, because unless they brought forward a student to school-based team at a meeting where the school psychologist has been there and they've talked about the possibility of a psych ed assessment, they may not have ever met the school psychologist. If you contact the principal at the school or the secretary, they will know who the school psychologist is that's attached to that school. And usually they know what other schools they're at. And then they can give you the name and you can do the email that way, because again, it's very difficult to contact us by phone because we don't have cell phones and
Right.
we just have voicemail. But yeah, sometimes the teachers legitimately have not met the school psychologist or even the.
But when your vice principal doesn't know, that gets a little bit scary.
It's a little bit scary, yeah.
Yeah, it's scary.
Okay, yes. Yeah, go ahead.
Just say a little bit about child and youth mental health, and I've
Yes.
got to run.
Okay, right, so yes, you have the floor, yeah.
So basically, child and youth mental health, I don't know if all the pediatricians know in terms of the process being changed in terms of how we take our referrals. We've now gone into the intake clinic model, where we ask families to come into the office to do the intake with us. So there's a lot of confusion in the community as to how this is being rolled out and the implication for families getting service. Because in the past, we would just take third-party referrals, so all pediatricians could just refer to us, fax the referral, and there we go. We screen it, basically it goes on our duty desk for pickup in terms of priority. So we don't want to discourage those third-party referrals. So the piece is that if you have a child in mind or a youth in mind that you think would benefit from some intensive therapy or a psychiatric evaluation, please do send in the fax. What we are going to do with you is we're going to call your office back and encourage that family to walk in to our walk-in clinic days. Right now, those days at Pacific Spirit, the team that I work at, are Tuesdays and Wednesdays. And on the north side, I believe they're doing Tuesday, Thursday, and I can send that information to you.
You know what, and that's excellent, and we'll put that up. I just want to say, when I had a patient that I wanted to send, I sent over my referral note and my consultation, because I thought that would be helpful. And the feedback I got is, don't bother with any of that, just send the patient. And I thought, that's a little bit of a shame. Don't you want to know the work that I've done already?
Yeah, no, there's a little bit of a misconception there, and this is basically, it boils down to sort of policy, and basically this is sort of driven from higher up in terms of how we're doing the work. So I think we don't want to get bogged down in that. We do, of course, we value any assessments or any intervention that's happened prior to them being referred to us. I mean, that gives us the context. So I don't know who you spoke to or you're speaking to, but we do value that information. It's just that we would still need to screen the family. They would still need to come in to do a face-to-face screening.
You would call them from my form. I fax the form, you call the family, right?
We're encouraging pediatricians to do that. We're encouraging.
Okay, but don't forget that your hours are 9 till 2 or something, right?
No, 9 to
So why am I
4:30.
4:30. Okay, sorry, 4:30.
Yeah.
Still, I mean, they aren't necessarily workable hours for a lot of kids, where the school's already complaining that they're missing school and all that. And you know, I thought that it was actually the last intake was 4.
The last intake is at 4.
Yeah.
And that's a one time, right? That doesn't mean that the child isn't going to get after school appointments, but that's a whole other thing that we run into. We've got 6 full-time clinicians. Everyone wants that 3 o'clock slot. Well,
Yes.
we're not going to be able to accommodate that. So
Yeah.
if school refusal is the issue, I don't care. Get your child in at 9 a.m., 10
Fair
a.m.,
enough.
11 a.m. We want to address your school refusal, right? So this notion of after school appointments, I understand, right? Single parents, like working parents, we try to accommodate that. But the reality is, even if we were running, till 5, there's only those few slots that we have, and then it's based on sort of our psychiatry hours too that we have at the team. So we do try to accommodate, but at the same time we make it known to families that these are our hours. And like I said, if youth have spares and that sort of thing in their schedule, we do our best to accommodate that. If there's a single parent can't drive out, we try to get out to the school to see the youth.
Oh, fabulous.
But let's talk about just in terms of the intakes, because that's the piece that's changed in the last 6-7 months. Is that's a one-time appointment. It's like going to a specialist for an appointment. So we have that expectation of families to take the time to come in and to do that intake with us.
Yeah.
You had a question.
In the past 2 weeks, I've sent probably 10 forms to child and youth mental health.
Right.
I mean, I have to call all the families back and say, if you need to walk in yourself, because you're not going to be contacted.
Did the pediatricians get that memo from Vancouver?
Yes, some of us did. Some of us did, definitely.
I mean, it's rolling out across the province, but right now in Vancouver, did the pediatricians not give that memo? You did get it?
Yeah, many of us did.
Okay, so sorry, somehow I missed the memo.
So ask your colleagues to send that to you. I can send that to you if you send your email, or we'll put it in.
Do you have a good website? Like, if you put in child and youth mental health, is there some good website that
we're working?
This is what I got this time.
Yeah. So it's a brochure.
Yeah.
Yeah. So that's
all the numbers are on
here. Okay, great.
So that's our brochure. I should have brought it.
Oh, okay, this is brochure.
Very good.
Like, we have just like one piece of paper, it says child and mental health, youth health, and there's like 2 phone numbers.
Yeah,
Vancouver
that's
and
exactly, that's the one.
I sent a child, and I mean, I gave mom,
The copy
phone number, and then she said, I phoned, and they told me, your child is not urgent, there is no suicide, there is nothing. So maybe she didn't actually talk to somebody like.
Did she walk in? Sorry, I just want to be clear.
She phoned, and her child was very anxious, didn't want to go to school, and I said, okay, you can phone this number, and she phoned in, and somebody said, oh, your child is not urgent because there is no suicide, there is no cutting, we just.
But I'm just, the reason I'm distinguishing is, did she call we have a crisis response team?
Maybe
That's
she
different.
called that one.
So that's what I'm thinking, because when you say cutting suicidal, we have an urgent
Right, the
cart.
cart, yeah. Well, the problem is that the parents don't have all these different acronyms in their heads, and they don't know, they pick up the phone and they call somebody for help, and then
So there's
they
2
don't
numbers.
realize.
So that's why I wanted to clarify. There are those 2 numbers that are on the intake. So if you're in the north side of the city, you call that. You can call either one. We'll direct you to the right place, right? But the piece that has changed, for better for worse, this is something that's directed from above us. We don't have a lot of control over this as child and youth, right? So this is something they're standardizing across the province to standardize mental health services, right?
Yeah.
So like I said, we're working with it, but in this, we don't want to lose families. Like I said, we don't, that is not, we're not trying to exclude families from seeking services, but I think we're going to have to get used to this interface and working with yourselves. As refers, like third party, it would be great, you would just fax the form, we take it from there. So now there's that extra step of them walking into
So
our.
I faxed the form, are you gonna, do you still call those families?
What-
You just have to walk in?
What the intake clinician is doing, because the thing is, they want 80% of our clients to be walk-in, and for the person referring to take responsibility for that. So what our intake clinician is doing, they're calling back your offices and telling them, so-and-so's form was faxed, please tell them to walk in on this and this day. And your admin probably knows it, you probably don't. So it is being taken care of, is what I'm saying, yeah.
Okay, Sarah has a question, and then we're gonna have to move on to
Yes,
other people.
yeah. No, I know.
Sorry, my question is related to just this.
Sorry.
My question is just related to this new walk-in model, just so I can guide families a bit better, because it was just rolling out before I went on mat leave. How long are they expected to wait there? Like a walk-in clinic at Penticton, they can wait for hours to see somebody. How long am I telling them to take off work or whatever?
So like I said, this is early days in terms of having this walk-in model, and it basically we launched it in March, and then summer came, so it was quite slow. Right now, what we're seeing is we're having a lot of individuals, of course, families, showing up for that 3:30, right? And then we're having to tell them, look, you know, we can't. And it hasn't been a big problem, I'll have to say, up until now. But school started late as well, so we're now slowly getting busier, right? The walk-in clinic hasn't been that people are waiting for hours. The longest somebody's had to wait, because there's 2 or 3 of us on those 2 days, because we're actually, the clinicians are participating in that as well. So we're trying to get those intakes done on those 2 days. So maximum right now, and I'll be honest, about half an hour, no more than that. And people come scattered, sort of thing. Now, and like I said, there is a possibility to book an appointment. We're not encouraging it, but if there is hardship, we're not going to turn away families, right? But we're not going to be booking appointments for, you know, everyone. We can't be doing that. But if there is a case for that, right? Like I said, we're not trying to exclude families from seeking us. We will book an appointment on those clinic days for those families. Yeah. So I guess the message is we want to still see all of the people that you're trying to refer, and we don't want this to become a barrier to accessing our service.
And in the case of undue hardship where they really can't just do a walk-in type of thing, is there a specific number they should be calling, or how do we find out?
We will try to, you know, we'll try to do that in terms of trying to take that information over the phone if they don't have transportation, or, you know, if there's other medical barriers, or like those, you know, 1% or 2% of the population is what I'm thinking when I think like that, right? We'll find a way to get the information from them, right?
Thank you so much. And you have to go. Okay, so, and I know people are wanting to go. I'm going to just give our other panelists, like, honestly, 60 seconds to say a little bit of something. So, Sandra, do you want to go?
Sure. I just want to say that when we do have the opportunity to work in partnership with pediatricians and counselors outside of the system, it's very exciting, because the care that is available then to that student is just, it's enhanced so greatly by the communication and by each other's piece of the puzzle of what's going on. So please don't hesitate, and I'm sorry that it's been difficult to get in touch with people, but no school would ever think that it was a negative thing to hear from a pediatrician or someone who's an outside agency that's trying to support a student. That's all.
Thank you.
I have just a question. Could you times happen that, for example, I discuss with a family that I'm willing to go to teacher, the principal, and they say, please don't do that. The teachers want to go to me. So ethically, what is my role here? I'm in ethics committee. So,
The school is the teacher. No one within the school is allowed to talk to you about the student unless there's a reason confidential information signed by the parent for that school year. So if the parents say no, then that's.
But I'm different from that.
Okay, so you get to speak next. You get to speak next.
But you are very scary.
You're very scary.
Not big enough to be that scary. But you have a big name, ministry. When people hear ministry, they say, no, thank you. They do not even listen to the end of the sentence.
It's so true. Yeah, so true.
It's really important to try and tell families that the ministry in the past certainly has been much more difficult to work with. I can't say that that's the role at this time. Certainly if you call us and tell us something seriously is going on, we're going to run and we have to respond and deal with it in the best way we can. But ultimately, we ask parents, okay, if you're not coping well, who do you know that can look after your child? We try and look at their support for their family before we even take kids into care. So I think that you're right, we are scary, but at the same time, I've always tried to work with my families very hard to try and keep those kids in their
Thank you, Brenda. Tamara, do you want to just say very quick, and then we have Jane and we have Aviva, and then we get to go home. Please go ahead.
So school counseling, just to get it back to sort of the scope of how we can work with anxiety in the school, I think are important pieces that we add are those relationship pieces with the home and the school, the nuances, knowing who the peers are, maybe attaching or separating some peers, modifying and adapting classroom environments, classroom teaching practices, and these are things that that we can do as part of our piece in the school.
Thank you. Jane?
I just want to thank everybody here because we're so dependent in psychiatry on the pediatric work, the community clinicians, the mental health team, the schools to do the work with the kids, particularly dealing with anxiety and mood disorders. So, I mean, this is just so exciting to see this collaboration going on. So, thanks.
On that note, we would love to have more advice from psychiatrists. It would be really great. Yeah, thank you. And thanks for your comments. Aviva.
So I was thinking about what I wanted to say in the end, given that I've spoken quite a bit. So I guess one thing is that I've been really grateful when I've had consent from parents to be able to speak to other community folks, not only schools but pediatricians, whom I often refer to and are really helpful for ruling things out or looking at developmental issues, and sometimes for having parents go through a medical route because that is their way in and they buy that. And so when I've had the opportunity, I know Elisa, we've spoken in regards to clients, and I think that's really been helpful. So I'm open and always excited when I can speak to pediatricians and we can kind of team up. And I know that there's not much time.
Well, I would just say that I mean, just like a plug for you guys, that Leap Clinic is just an awesome group of private psychologists, and when my patients can afford to go there, it's such an easy way to manage my patients. It's just really fantastic. But unfortunately, we're limited, the parents are limited, and as we were hearing already, that moving from Burnaby to Vancouver means that parents do have it's a little bit more affluent community, and so parents can afford that. Anyway, so we're going to finish. Thank you so much, everyone, for coming. And we just have to really give a big hand to Stephanie, because really it was an idea that's been around for 100 years, and it just takes a person to actually take it and do it. And it has been a heck of a lot of work. You may not realize it, but just the various requirements and giving us credits, like, oh my gosh, it's just amazing. And so I'm very grateful to Stephanie for making this happen. So we will, if you guys, I know everyone's tired and wants to go home, and if you have ideas for the next one, it's clear we need to talk about designation, but there's lots of other topics that we can